Please welcome the incomparable Dr. Ben Carson.
When people's lives are at stake, the last thing you want to do is lower standards.
To say DEI is bad, I think is misguided.
At the University of Pennsylvania Medical School, my name was wiped out of the history of the kidney division because I pointed out a study that showed that minority residents were performing less well.
We're diving into one of the most polarizing debates in America. Well, tonight we're diving into one of the most polarizing debates in America, the role of diversity, equity, and inclusion, often called DEI. But we are focusing specifically on its impact in the field of medicine. Now, this affects us all, so you need to lean in because I want to hear from you all of you here, all of you at home. There is a push to ensure that our healthcare system is inclusive and equitable for everyone, regardless of race, gender, or background. And I could not agree more. Definitely an admirable goal, but not everyone agrees on how this should be done or if it should be done at all. Some argue that DEI is essential for addressing health disparities. Others believe that it's nothing but a quota system that is dangerous at best and could lead to unintended consequences, such as lower standards of excellence or division among healthcare professionals who may resent being forced to work with unqualified colleagues. Now, we're going to hear from both sides of the debate. Is it a prescription for progress or a flawed approach to a very real problem that deserves serious attention by serious problem solvers? My first guest is a renowned neurosurgeon, former Secretary of Housing and Urban Development, and a former presidential candidate. He's also the founder and chairman of the American Cornerstone Institute, Dr. Ben Carson. He climbed to medical heights that most can only dream of, and he says he wants to see others reach success like he did, without DEI.
When I got to medical school and I started listening to the incredible things the neurosurgeons could do with the brain and the spinal cord, I rapidly started moving in that direction. I was approached by many people because at that time there had only been 8 black neurosurgeons in the world. But of course, the Lord does not disseminate talent based on race. And I took to it like a duck to water. DEI as being currently executed is not effective because instead of alleviating the reasons that we don't have more minorities in scientific fields, we simply lower the standards and admit people who aren't particularly ready for that field. You don't want to have a situation where everybody is wringing their hands and regretful of the fact that the surgeon was not prepared appropriately to do a complex case. DEI is dangerous because people's lives are at stake. There are plenty of people who go around saying DEI and the banning of DEI is a racist thing. And in some cases it might be, but the fact of the matter is it's a lot easier to blame racism than it is to blame the fact that maybe you didn't study hard enough.
Please make welcome the incomparable Dr. Ben Carson. Dr. Carson, so good to see you.
You too.
Thank you. Thank you so much for being here.
It's a pleasure, thank you.
You entered the medical system as a student when?
1973.
You say that a counselor told you at one point, you seem very intelligent. I bet there's a lot of things you could do outside of medicine. They were steering you away. Why?
I had done very poorly on the first set of comprehensive examinations and was sent to see my counselor, and he basically said, I'm not cut out for medicine. And I just went back to my apartment. I was devastated. Only thing I'd ever wanted to do since I was 8 years old was to be a doctor. I finally am in medical school, the last hurdle, and the person who's supposed to help you tells you to drop out. So I just prayed for wisdom. And I started saying, what kind of courses have I always done very well in? And I realized I did very well in courses where I did a lot of reading. And I said, what kind of courses have you struggled in? And I realized I struggled in courses where I listened to a lot of boring lectures. Because, I don't get anything out of boring lectures, zero.
Yeah.
And I was sitting in 6 hours worth of them every day. So I made an executive decision to skip the boring lectures and to spend that time reading.
Yeah.
The rest of medical school was a snap after that.
Really?
And years later, when I was back in my medical school as a commencement speaker, I was looking for that counselor because I was going to tell him he wasn't cut out to be a counselor.
Now, you believe there has been discrimination in higher education
Sure.
generally and the medical profession in particular, but that DEI is not the fix.
Right. I sympathize with the proponents of DEI, and I understand what they're trying to do. They're trying to make the people who are doing the treating look more like the people who are being treated. And hopefully that will make them identify more with them. I'm not sure that's a legitimate goal, to be honest with you. I mean, different people have different kinds of diseases that are predisposed to different things because of the environment, because of genetics, because of a whole host of factors. People are people. And there's a whole host of things that impinge upon their health. We need to treat them as people. When I took somebody to the operating room and I peeled the scalp back and took off that bone flap and opened the dura, I'm operating on the thing that makes that person who they are. It's not their skin color or their hair texture or the shape of their nose, it's their brain.
You hear that a lot, that patients respond better if they have a doctor like them, whether it's Hispanic or Black or whatever. But the empirical data doesn't support that at all.
It doesn't support it in the slightest. And when I was a fresh attending neurosurgeon at Johns Hopkins, I was the chief of pediatric neurosurgery at a very prestigious hospital. And I would see some of the white patients who were obvious rednecks come in. And you could see the wheels churning. They say, this guy is young, and he's Black, and he's the chief of pediatric neurosurgery at Johns Hopkins. He must be really good. And then I would see some of the Black patients who would come in, and they said, this guy is Black, and he's 33, and he's the chief of pediatric. I'm not letting any affirmative action operate on me.
Yeah.
But, later on, when I became well known, everybody wanted me. They didn't want it white, they didn't want yellow, they didn't want brown, they wanted me.
Yeah.
Because I offered them something they wanted, which was excellence when it comes to their care. This is where we need to get to in America.
I hear DEI people say this isn't a quota system, we're not lowering standards, we're not eroding care. And I think in many respects, that's true. What I'm concerned about is, are the graduation standards lowered? Are they in some way less prepared? And I've seen study after study where colleagues are frustrated that they're working with less qualified individuals that were given consideration to get into a program. And that can be because they were Black, it can be because they were a white legacy that got in because their family gave $1 million to the school. Whatever the compromise was, this is not an area where it should be made, it doesn't seem to me.
No, clearly, when people's lives are at stake, the last thing you want to do is lower standards. You want to make sure that you know what is required. But, we're smart people. We know what works. We have a long history of what works and what doesn't work. And we should rely on that. And when it comes to preferential treatment, that should never be based on race.
Coming up, we're going to add someone to the conversation. And this next guest says Dr. Carson's story inspired his medical journey. The two will meet face to face although they don't see eye to eye. Next. Every notification on your phone announces another wave, a hurricane threatening lives, an East Coast labor strike threatening our supply chain, an international conflict threatening our peace, or an assassination attempt threatening our democracy. Supply chains for medications can be unreliable, but there's a way to feel safer in this uncertain world. Please research how to get your own supply of medications in case of a small or more significant emergency. I urge you to invest in a JACE case today. It's an emergency medication kit containing life-saving antibiotics that treat the most common and deadly bacterial infections. You'll fill out a simple online evaluation and customize your case to include add-ons like ivermectin, EpiPens, and more. The time to prepare is right now. Mention my name and you can receive a discount on your JACE case. Just go to jace.com and enter promo PHIL at checkout. That's promo code PHIL at jace.com. Get the right meds the moment you need them. My next guest, Dr. Bonzo Reddick, is a professor and former Associate Dean of Diversity and Inclusion at Mercer University School of Medicine. He believes DEI initiatives are crucial for bringing together communities.
I always had a love for STEM, so science, math, physics. I knew I was going to do something in the science field. I was in high school. My mother bought me the book Gifted Hands by Dr. Ben Carson. And that was one of the things that really piqued my interest in not only medicine, but also in service. During college, I actually went to 2 different summer programs that were focused on recruiting and retaining racial and ethnic minority students. Those programs gave me exposure to what medical school was like, but also gave me the confidence that I could do it. One of the misconceptions about DEI is that it's letting unqualified people in over qualified people. That's not the case. No one ever had the lower standards for me. I scored in the 98th percentile on my family medicine board exam. So when I hear a lot of the backlash about DEI, I realize that people are either significantly misinformed or they're being intentionally misleading. My experience with DEI has been that it fosters unity. People fixate on things like GPA and MCAT scores. That's not the full measure of what makes somebody a good physician. You also want somebody who's compassionate. People conflate DEI with race. DEI is a general term about increasing diversity, equity, inclusion for all people. Whether you're from a rural background, our military veterans, people with disabilities, people who speak English as a second language, LGBTQ. Inclusion means that anyone that comes in is welcome. We should all support DEI initiatives. They make our organizations more efficient, they increase financial returns, and improve health outcomes for our communities.
Describe the family and background that you come from.
Sure. So my parents have been married since 1971. Mom was a high school Spanish and French teacher. So she's trilingual, taught us languages at a young age. And my father's an attorney and also a magistrate court judge as well.
So education was at a premium in your family?
Absolutely. Education was prioritized during the summers. My mother insisted that I study for a certain number of hours before I was able to go outside and play.
And you say during your residency, you were usually the only Black male in a room full of doctors.
Residency and beyond. When I go to medical conferences, I'm often one of the few Black men that are around.
Right.
Only about 2.5% or so of physicians are Black males.
Yeah. And you disagree with Dr. Carson on his position. What do you disagree with?
So 2 points real quick. So I want to stress that point is that as a society, we have decided that that's how we maneuver. We try to make things equitable. It doesn't mean equal, it means equitable. So for example, everybody doesn't get a car. You might not be able to afford a car. You don't get one, but everybody gets access to public transportation so that everyone has the opportunity to go to work or go to their kids' activities. So that's what the framework of equity is. We spent the first segments focusing a lot on diversity. That's only the D in DEI. The equity and inclusion is important as well. I was at an organization one time that held a mandatory retreat on Rosh Hashanah. So pretty much no one who was Jewish was able to come. So literally inclusion is just being culturally aware. So that's what the idea of inclusion is. So just kind of talking about medical school admissions and using that as a broad stroke to say DEI is bad, I think is misguided.
All right. And you say DEI is not where minorities get an advantage, and it's not reparations. You're not putting it on that level, but I think all three of us agree that we want equal opportunity, and we don't have that in America.
Yeah, clearly we need equal opportunity. in everything. And we need to start at an early age. That's why my wife and I started the Carson Scholars Fund. We give scholarships to students starting in the 4th grade for superior academic performance, and they're only compared with the students in their school. So you don't have all of those socioeconomic variables going on. The other thing about DEI that I'm not particularly thrilled about is spending so much precious time teaching medical students about things like transgenderism. And, if a guy comes in and he thinks he's pregnant, and, instead of sending him to the psychiatrist, altering all kinds of, these kinds of things don't make sense. We need to do things that are logical, that make sense. That doesn't mean that we should discriminate against any particular people, but we don't take what is abnormal and try to make it normal and try to conform everything else to it. We learn what true compassion is, and we adjust so that we can accommodate those individuals. That's what logical people do.
So first of all, it was great to hear about the program that you have for young children. That sounds like a DEI program to me. It's not some kind of preferential treatment. It's saying that, there's certain groups that are disadvantaged, which we've agreed, we all think that's important to increase opportunities for people, right? Not at the expense of someone else. So a program that targets a certain group, whether it's race, ethnicity, geographic location, and kids living in a rural area, that's what we're talking about when we talk about DEI initiatives. So it's reaching out to people intentionally to try to increase interest. Kids who might otherwise be dissuaded from going into neurosurgery like you were. This is something that can actually help a lot, because we know that the biggest predictor of somebody going to work in a rural area is actually being from a rural area. So the medical school where I'm on faculty, we actually have a mission to increase the workforce in rural communities. So we do have an admissions process that looks favorably upon people from rural backgrounds. That's a DEI initiative. But interestingly, I never hear people complain about initiatives that focus on things like rural background, but we do hear it about race all the time, and that's what we tend to get fixated on.
And DEI is good if you take the race part out of it and you look at the circumstances.
So you're only against DEI if it's about race, but you're not against DEI in any other circumstance?
I'm not against diversity and inclusion. I don't particularly like the equity part that says we have to have equal outcomes for
Equity
everybody.
is not equitable. It's not the same thing.
It shouldn't be.
It's not the same thing.
But a lot of people
No experts, no serious
there.
scholars consider equity and the same thing as equality.
The problem is when race gets involved in it and people talk about that, discuss that, speak out about that being weaponized, people get their jobs taken away, people get judged, people get disciplined because of the race element to it. They don't get their jobs taken away because they talk about rule, but they do get their jobs taken away if they talk about race.
So, and again,
that's just a fact.
I'd ask again, I'd have to have a specific scenario to kind of give you an example or kind of rebut to that. But again, the point about equity is we're focusing so much on the applicants, on medical school applicants. What equity is it should be focused on patients and communities. We're trying to improve the health of populations. So for example, you mentioned about transgender patients, right? So you're focused on are we trying to influence people to change their ideology? That's not what health equity is concerned about. Health equity is saying, a transgender patient has probably anywhere from a 3 to 10 times higher rate of attempting suicide compared to other people. It's looking at somebody who's lesbian and saying—
But it's 12 times higher for people who undergo transgender surgery.
But again, I'm not focused on that. What I'm saying is that what I want to do is improve the health of everybody. Transgender, cisgender, doesn't matter. I'm trying to improve the health of everyone. That's what my mission is as a physician, also my mission as a Christian as well. And so what I'm saying is, for example, lesbian patients are more likely to die from cervical cancer, even though they don't have that many significant changes in risk factors. So for you to focus and say, I'm going to make an attempt to improve screening of lesbian patients, for example, that's a health equity thing. It's not making any kind of judgment about behavior or anything like that or about ideology. And I'm focusing on patients, not on the people.
If everybody who's pushing DEI were as reasonable as you are, I don't think it would be a problem.
So here's a question, though. I would challenge Dr. Carson on that, because I do think there are some people who are very vocal and who say some outlandish things, and they sometimes get the attention. But in general, the real true scholars and serious scholars of DEI are talking about health equity focusing on improving the outcomes of people, not trying to change people's ideology.
But you're talking among yourselves, and then you've got people that I call the tyranny of the fringe that are out with megaphones and they're dominating the narrative in America, and people are afraid to stand up and push back for fear of getting canceled, for fear of being labeled racist, for fear of saying what needs to be said, because when they do get canceled. Now, we gotta take a break quickly. Coming up, we're gonna add two more doctors to the conversation who both say patients are in danger. One says DEI is the poison, the other says it's the antidote. We'll add them to this conversation next because, look, we do have to have a safe place to talk about difficult things. And that's why Merit TV was created. We want to have a place where we can have an open debate about these things without fear of retribution. Now, we may all be labeled racist for this. We may all be labeled transphobic for even questioning that. But they'll just have to do what they have to do. We're going to have an intelligent conversation about this one way or the other. We'll be right back. Are you overwhelmed with back taxes or unfiled returns? Well, you don't have to face them alone. Tax Network USA is here to help. Tax Network USA, the nation's premier tax relief firm, has negotiated over $1 billion in tax relief for clients. Our services include penalty forgiveness, hardship programs, and offer in compromise solutions for lump sum settlements. Whether you owe $10,000 or $10 million, our experts are ready to assist you. Even if you're behind on taxes due to missing personal or business records, Tax Network USA can guide you through the process. Protect your financial security with guidance from Tax Network USA. Our experts provide strategic advice on reducing or eliminating your tax debt. To schedule a complimentary consultation, call 1-800-958-1000. Visit tnusa.com/Dr. Phil. Don't let the IRS's aggressive tactics control your life. Empower yourself with Tax Network USA's support and take charge of your financial future. Visit tnusa.com/Dr. Phil today. My next guests are both doctors who see the medical field very differently. Dr. Stanley Goldfarb was Associate Dean of Curriculum and Professor at the elite University of Pennsylvania School of Medicine. He is now the chairman of Do No Harm, an organization aiming at combating discriminatory practices in medicine. Dr. Chris Purnell is the director of the NAACP's Center for Health Equity. She says privilege and politics have always been a part of healthcare disparity.
I became a public health and preventive medicine physician because I loved things like policy, politics, community, history. DEI has certainly helped me.
I was a nephrologist caring for patients with all forms of kidney disease. I think that diversity and inclusion is rather irrelevant to the goals of medicine. Unless it benefits patient care, it should not be part of the criteria for getting into medical school or becoming a physician.
Understanding a history of racism or sexism in this nation has never been a detriment to anyone receiving good, high-quality, safe care.
DEI in healthcare is dangerous because it's divisive and discriminatory. There have been a number of issues where attempts to undo what's been proposed to be discriminatory practices has actually led to worse medical care.
DEI actually is life-saving because it says, I understand your specific needs.
The most important thing in medicine is that we worry about the patients, and we don't worry about society as a whole. I think critical race theory demands that individuals be categorized as oppressor or oppressed, and I think DEI is the implementation of that. For example, the Jews turned out to be oppressors in the current era, and that's why we've had such an uprising of anti-Semitism in this country. And anyone who's been an oppressor, mostly white males, can really do no right.
Words like critical race theory, woke, and DEI have been made into slurs, and frankly is anti-Blackness, is anti-humanity. If we really had a vested interest in everybody achieving their highest level of health, we would have an all hands and an all hearts on deck mentality. And that's what health equity requires.
Thank you for being here.
Happy to be here.
Thank you for being here.
Pleasure.
I was interested in what you just said, that you take offense to people having a negative reaction to it. Do you acknowledge the fact that it has been weaponized in many situations and that faculty members, administrators have been, in some cases, severely disciplined, criticized, and canceled for even asking questions about it, challenging it, wanting to have a dialogue about it?
Let me tell you a little bit about my story. During medical school, right, my childhood hero said to me as a young Black woman who wanted to become a neurosurgeon, what man is going to want to marry you if you become a neurosurgeon, right? So immediately I'm faced with this sexism and genderism, and I don't necessarily feel that a person who looks like me or has the experiences like me is of value in that organization. Sure, I'm going to study hard. Sure, I'm going to work hard, but I don't feel as of value. And that has followed me throughout my career, despite the fact scoring well, performing well in academic environments, despite the fact taking on very senior roles. Look, during the pandemic, I was one of the senior healthcare administrators at a safety net hospital in Newark, New Jersey. We got slammed by that pandemic, right? But as
Thank you for doing that, by the way.
It was my honor. It was important for me as a Black woman to be seen, me as a Black woman physician, me as a Black woman physician leader, to be able to say to communities who were suffering disproportionately, I understand the harms of racism. I understand the harms of classism. I understand the harms of sexism and genderism. And when I did do that, Dr. Phil, I was actually disciplined. I was put under investigation at my hospital. I was told that I was being divisive. I was told that I was disrupting the fabric of the organization. So that's how terms like DEI, even critical race theory, which is an academic and legal framework, have been weaponized against those who are seeking to cultivate a shared human experience and to understand from a historical, factual, and literature influence base how we can ever eliminate the disparities that we have. Last thing I'll say on this subject, the traditionalists will say, we need to keep medicine and healthcare the way it is. Well, if we did that, people like myself and other communities would continue to live sicker and die sooner. I say we need to change and disrupt it.
What do you say?
Well, if you go to the University of Pennsylvania Medical School website, my name was wiped out because I pointed out a study that showed that minority residents in internal medicine residency programs around the country, published in Academic Medicine, the Journal of the Association of American Medical Colleges, said that they were performing less well. And I pointed that out. I say, are they performing less well? Basically in a tweet. And I was canceled for that. But I must say that, a lot of what I've heard here, I agree with. This is not about the medical profession. It's not about the students. It's about the patients. I understand there's been historic lack of opportunity for Blacks and other minorities in this country. That's a problem. And there are fields where that can be easily made up. But there are some fields where it's not easily made up. Pilot school, medical school, engineering school, things that it's critical for the health and the safety of the public. We can't be concerned about the individuals who want to practice in those fields. We can only be concerned about the outcome and the quality that the service or healthcare in this case that patients are receiving. That's all that really should matter.
When I was 6 years old, I remember going to Chattanooga, Tennessee, and seeing whites only and coloreds only signs and having people explain to me why you needed to pay attention to that. In the same lifetime, we now have Black admirals and generals and CEOs of Fortune 500 companies and heads of foundations and university presidents. We've had a Black president. To say that we haven't made tremendous progress is crazy. Are we nirvana yet? No. Do we still have a ways to go? Absolutely. But we've made tremendous progress. And we've made that progress because of some of the values and principles that we hold as a nation. And we should look at that.
The question is, what's the fix? The question is what to fix. It's not necessarily that one thing.
It's health equity.
We have to take a break. Coming up, why Dr. Goldfarb says he doesn't believe there are minority applicants to medical school who are qualified and being rejected. We'll talk about that when we come back.
In medicine, less than 0.4% of physicians are American Indian, less than 6% are Black, and less than 7% are Hispanic. Studies show that the more diverse our healthcare workforce is, the better our healthcare system is overall. The reason why the number of underrepresented minorities in medicine is so low is intentional. In the early 1900s, for example, the Flexner Report actually led to the closure of most of the medical schools that trained Black people. It wasn't until the Civil Rights Movement in the 1960s and the Civil Rights Act that actually corrected this and allowed for Black individuals to be able to apply into medical school. Understanding the disparities helps us understand why diversity, equity, and inclusion initiatives are necessary.
I think everybody agrees that we want that. I think everybody agrees that we want to have as many people from as many different walks of life into the field of medicine. A lot of people say the reason you want that is because you have better outcomes if you have doctors that look like their patients, doctors that have that commonality. There's no empirical evidence for that. It's inconclusive, but it trends towards no, that doesn't improve outcomes. You're shaking your head.
There's an empirical
evidence.
study of more than 3,000 people that actually show, hundreds of hospitals that actually show decreased mortality in Black patients when there's an increase of underrepresented minorities in that population. Also studies showing the decreased infant mortality when you have increased Black physicians as well.
That's true with infants, but it is not true with the population in general. And the meta-analysis shows that it doesn't matter. What matters is the quality of care.
When there is concordance, it is proven in the data that people get better clinical preventive services, meaning they get access to screenings. For instance, cervical cancer screenings, HPV screenings. Also, people share more accurate histories because they believe that the person across the table for them has empathy. Does empathy only matter because of race or language spoken? No, but it does matter because of shared human experience.
Okay. So Dr. Phil is right.
Thank you.
Dr. Chris is right too.
Our organization, Do No Harm, has researchers that have looked at this very carefully. There are many, many studies of this issue. There are 5 systematic reviews of this issue. They ask the question, is there better communication? Is there better happiness on the patient's part? Does racial concordance really improve health outcomes? Well, there are no long-term health outcome data that are worth anything. And in terms of these 5 systematic reviews, 4 of them showed there was just no difference. You can certainly pick out a case here or there, and you can pick out an example where there's been bad communication. But there's bad communication between white patients and their doctors as well.
Definitely.
And so the question is, how can we improve healthcare disparities? Now, if you decide that the way we can improve healthcare disparities is by changing the characteristics of the delivery system, as opposed to changing the sort of things that Dr. Phil was talking about, the access to care. And I totally agree with what Dr. Reddick said. This is about improving access to care, but access goes both ways. When Black women show up with endometrial cancer, which is a terrible disease, they come with their disease far more advanced than when white women show up.
But why do they come when their disease
Well,
is
that's
far
a
more
good
advanced?
question. And that involves
Why?
understanding symptoms. It involves access to care. I certainly agree. If a woman is working 2 jobs and
Why
can't
would
get
that
to the
woman have to
healthcare
work 2
and
jobs?
can't get to the
Why would she
healthcare
have to
system,
work 2
well,
jobs?
that's an issue. But that's
Right.
not an issue for the medical.
Yes, it is.
No, it isn't.
You're speaking with the healthcare
That's an
ministry.
issue. That's an
Yes, it
issue
is.
that's an issue
Yes.
for politicians.
Patients who were unhoused, patients who had behavioral mental health issues were showing up in our emergency departments, not necessarily because they had a clinical reason, but they had some other social reason. When we did partnerships and collaborations to get those needs met, even if they weren't purely clinical, those people were no longer using emergency room services, which was a drain on our system. So that's why it does matter.
We're talking about which physicians should get a chance to
Yes.
treat patients. And what you're talking about is public health issues, which is a very different world.
I disagree.
That's really been the issue here of conflating these 2 kinds of things. And my concern is that when that patient shows up at that emergency room, that person who's caring for that patient is the most qualified individual.
Exactly.
And that's that's the issue here, as far as I'm concerned.
I have to take a break. Final thoughts when we come back. We've been talking about DEI programs in medicine, and if they are the right way to bring more minorities into the professions, more rural individuals into the professions, more of those that are unrepresented in the professions. Hispanics represent 18.5% of the population and 5.8% of doctors. Blacks, 13.4% of the population, 5.7% of doctors. Native Americans and Alaska Natives, 1.3% of the US population and 0.3% of the doctors. So clearly there is a underrepresentation compared to population proportionality. The question is, what's the best way to do that? I've written a book called We've Got Issues, How to Stand Strong for America's Soul and Sanity. And in there, I am very much against DEI as it is being practiced. But I think the much better approach is to get into these underrepresented communities very early on and prepare these students so they're just as competitive as anyone else. And the problem is they're often low socioeconomic status, whether they're rural or inner city or whatever, so there's a low tax base, which means the schools don't have much money to work with. That has to be fixed. They should have every educational opportunity as anybody in the United States. And I think if we intervene early and give the educational opportunities to develop these young minds, then we can see them flourish. And I think there can be a huge shift in one generation if we get into those schools and get to those children early and give them every opportunity to develop their bright young minds.
I just want to second what you just said. That's so very important. You know, when I was a kid, and I was a terrible student until my mother made me start reading. And as I read about scientists and surgeons and philosophers and entrepreneurs, I began to realize that the person who has the most to do with what happens to you is you. But in the Black community in particular, we don't have enough people applying to medical school because we don't have that dream starting early enough. It's the early preparation that will make the difference. Yeah. And don't wait till the end to try to change things.
I agree. Dr. Reddick?
I think we spent a lot of time today talking about the D in DEI, and specifically racial and ethnic diversity. So I think one of our shining examples of DEI happened in California with maternal mortality, where they had a maternal death rate that was about 4 points above the national average, dropped it down to 14 points below the national average. So in the United States, you're more likely to die in childbirth or pregnancy compared to other industrialized countries.
If you're 50th.
Yeah, and if you're a Black woman, your rate is 3 to 4 times higher than the rest of the population. They were not only able to decrease just overall maternal mortality, they decreased Black maternal mortality with specific system changes. That is a classic DEI initiative and something we should be proud of. But instead of talking about that, we focus on things like medical school admissions. And then the second thing I want to just piggyback on what Dr. Goldfarb said was this idea of like, we shouldn't be focusing on some of these social and political issues. And what we found out is that social determinants of health, which are the non-biological things that affect health outcomes, actually have a bigger influence on health outcomes than even clinical care. So in my clinical care that I practice at a healthcare for the homeless clinic. So every single week I address people's social issues. And I think that is a role of a physician.
Mm-hmm. Well, final comment?
And the focus has to be on making sure that the patients get the optimum care. And if you start compromising on the academic potential of the individual that you're letting into medical school, you're going to lead to the kind of data that we see, which is many, many minority residents and trainees are just not performing as well as we had expected that they would. And I think in part it's because we've compromised the quality of the individuals that we're taking in. There are plenty of incredibly brilliant Black students who could be terrific physicians. They should be the ones that have the same academic potential and the same academic achievements as anybody else. And then the basis should be on their ethical statements and their empathy and their kindness. These are all critically important parts of a physician after we've identified the ones that have the greatest academic achievements.
Yeah. Final comment?
Yeah. I think it's so important that not only all of us, but that the public understands DEI is only a tool, the roadmap to build a more just healthcare system that's inclusive. Because if we don't do that, we will never solve the healthcare disparities that we have. And finally, to stop focusing on the red herrings that those who are of different communities and different ethnicities are less qualified, but to look at the barriers that are impacting whether or not we are reaching into those communities and mining them for all the success that they have. That's the American dream we all should be focused on.
I want to thank Dr. Ben Carson, Dr. Bonzo Reddick, Dr. Stanley Goldfarb, and Dr. Chris Purnell for joining me tonight. And thanks to you at home for finding us here on Merit TV. We spent extra time discussing this topic, and some of what did make our broadcast will be on our website, and we'll have even more information about tonight's show. So make sure to log on to drphil.com. This is important, and one of the dumbest things somebody can do is waste a talent pool, like the black talent pool, the rural talent pool. And I promise you, those organizations that do that because they're racist or they're judgmental or whatever, in the long run, they won't compete well because they will miss a huge, huge talent pool. But in the meantime, we need to do what we can to find the solutions. I told you what I think my solution is. I think we can make a huge difference in one generation. Thanks for being here. We'll see you next time.